Schedule 2s are the very addictive drugs, all the way down to Schedule 5, which are very mild, the lowest abuse potential, but still dangerous. Some of the effects of heroin use, short-term, in the central nervous system. That's where the euphoria happens. That sedation, that altered level of consciousness. You get dry mouth, skin conditions. Your respiratory system slows as you become more relaxed. That's what's killing people. That's where these overdoses are happening. Is when you take too much or so much of an opioid, that euphoria, that intense relaxation is so much that your respiratory muscles, your diaphragm, your intercostal muscles become so relaxed that they physically cannot function, and they physically cannot breathe, if that makes sense. And that's why these overdoses are happening, because they are so relaxed, they are so out of it that they can't breathe. You go without oxygen for so long, and you go into cardiac arrest and then die. Some of the long-term effects of heroin addiction, tolerance, and dependence, some of those things we talked about before. Infections, not only in the heart, but all over the place. Abscesses. Abscesses is the thing that we're getting ambulance calls for all the time, and a lot of times they end up being drug-related. Pneumonia, liver problems, collapsed veins. An unintended effect of this of addiction is, when you're using IV drugs, and your veins can only take pin stab so much before they fail. They collapse. There's so much scar tissue. They've been punctured so many times that they just do not function anymore. And now you start to affect the vasculature and the distribution of blood, circulation of blood throughout your body, which can cause a lot of issues. I heard a story of someone having a former addict having a heart attack and needing an IV, needing life-saving drugs. Couldn't do it because he had no vascular access. There was nowhere that they could get an IV on. And fortunately, there's other methods of getting these medications in them, but that's something to think about down the road with these long-term effects. Risks and effects of heroin use. Obviously, death is the worst of them. These people are at risk for hepatitis C, HIV, other bloodborne diseases because they're shipping needles. One of the big things too is socioeconomic effects. Effects on your family, your friends, your career, your finances, and then there's also trouble with the law, which can affect a lot of things as well. So when you hear that term like track marks, it's kind of a slang term for really a puncture wound that the individual gets from when they're injecting the heroin. And what can make this so bad and so nasty for the individual is that Janice said they as soon as they get it, they use it, and they're immediately thinking about how they're going to get their next dose, and they're doing this on a daily, sometimes multiple times per day, and so these sites along their arms, along their veins, are getting punctured with a needle very often. A lot of times these wounds don't have time to heal before they're injected again. And so, that's where you're getting these track marks and these scar tissues. An injection once, your skin's going to heal fine, but you inject, a dozen, 2 dozen times in that one spot, you're going to get scar tissue build up, and it's not going to go back to normal. So this is what we're seeing with these track marks, and not to mention these people are prone to infections, and that's where the abscesses come from.
And their needles probably aren't clean either. Sterilized.
Yeah. So here's again, right here what you got is an abscess wound, an infected wound. And when I talk about repetitive injections, building up scar tissue, this right here is scarring, but that's just from repetitive puncturing with a needle right along the vein. So yeah, it's pretty nasty. Again, more scar tissue. And what that can do with someone's arm. These are like before and after pictures, which I think, kind of really bring it home for some people, and they can see like, what seems to be a normal looking female, could be anyone's friend, sister, neighbor, and then, looking, after drug use, what it can do to an individual. Nasty drug. When we respond to an overdose, what it will usually come in as is sometimes it'll come in as an overdose, and sometimes it'll come in as a person not breathing. Now there's a bunch of different reasons why someone could have a medical emergency and stop breathing, but lately, if we are dispatched for a person not breathing, a lot of times it ends up being opioid or heroin related. So they're high, their sedation turns to unconsciousness, which quickly starts to affect the respiratory rate. The respiratory rate slows, it continues to slow, it slows and then it stops. Their muscles become relaxed, they become too relaxed. That's why they can't breathe anymore. As your body begins to shut down, mechanisms begin to compensate. So we're talking like, because you're getting decreased oxygen in your body, so your heart rate goes up. You start sweating, your body's just attempt to cool your body off. Your body literally struggles to breathe with every ounce of energy it has in there to get air into it. This leads to respiratory arrest, which is when your breathing stops, and that leads to cardiac arrest, which is when your heart stops. And once your heart stops, you got 5 to 7 minutes before it's all done. So as we arrive, we're finding these patients in respiratory distress, or they're not breathing at all. We're finding them with what's called meiosis, or pinpoint pupils, and I'll show you what that is in a second. That is one of our key indicators of opioid use, opioid overdose, that sort of thing. There are some neurological conditions, strokes, brain bleeds, hemorrhaging, that can cause pinpoint pupils. However, the majority of the time it's opioid related. And you'll see in a second these pupils are like a pinpoint, and really, like I said, that's the telltale sign that, of opioid use. Clues on the scene will cue us into that too. If someone overdoses, a lot of times they don't have time to clean up. So, pertinent past history of drug use. A lot of times the family, friends, bystanders can provide this information, and sometimes it can be the individual themselves. A lot of times they're upfront and honest about it. So that pinpoint pupils I was talking about, you guys all know what a normal pupil looks like. That's tiny. Like I said, when we see, if there's something going on with a patient, they're unconscious, and they're having some kind of medical emergency, and we haven't figured it out yet, if we look at their pupils and they look like that, they're getting Narcan. So, as EMS providers, what we do when we respond to these overdoses, we do a full assessment of not only the patient, but the scene. So we're looking at the scene for for clues, for indicators. There's also making sure that the scene is safe. Obviously, if there's a safety concern, we're not going close there until the PD has responded and that they've secured the scene for us. We do a full assessment, to assess the airway, breathing, circulation, and a physical assessment from head to toe. We're going to support their airway functions. Before we give them the Narcan, we need to start getting some oxygen back into their body. So we'll use, we'll hook up what's called a bag valve mask up to some oxygen. We'll start ventilating for them through, it's a round bag that we're able to squeeze and sends air in through a mask into the mouth, into their airway. So we'll support their airway and breathing functions to kind of get them oxygenated again. Then we'll administer the Narcan. Most of the time we end up giving 2 milligrams. It's a pretty standard dose. However, you know, the EMS providers and healthcare providers, we can do lower doses if, you know, maybe we think that they're just slightly over that threshold of, you know, going unconscious, and maybe we don't want to reverse it too much. So this drug we can give intravenously, which is through an IV, intramuscular, which is like a shot in the arm, like you would like an EpiPen kind of thing, and then lastly intranasal. Now intranasal is obviously the preferred route because, you know, we're not dealing with needles at that point, and you're really reducing risk at that point for, you know, the healthcare providers and anyone that's there of disease transmission. And then other supportive therapy, transport to the hospital. You know, if they're nauseous, we'll give them nausea medicine. If they're dehydrated, we'll give them IV fluid, that sort of thing. You know, we'll treat their symptoms and do what we can to, you know, to get them feeling better and making sure that they're okay. So the Narcan that you guys have heard about, naloxone, Narcan, generic and trade names. It's an opioid antidote, and like I said before, your body has opioid receptors all throughout the body. When you ingest an opioid, it goes to those receptors, and those receptors, when they're activated, cause that intended effect. What Narcan does is competes for those receptor sites, and so it'll just knock the opioid right out of the site, and Narcan doesn't cause all those symptoms that the other opioids do, the sedation, the respiratory distress, the euphoria. So it's really just, it's an antidote. It will reverse the symptoms, and this works for all opioids. So all those opioids I went over before, the heroin, methadone, oxycodone, Vicodin, methadone, all those related opioids, Narcan works on.
Joe, what's the time frame for that? You give them that 2 milligrams before it can come back?
So again, bioavailability. The same way with, I think someone asked about the different routes of taking the drugs. The different routes of giving the Narcan can affect how quickly it happens, how well it happens. So the best way to do it is to give it intravenously, because they're getting most of the drug that way. The problem is it takes time. It takes a couple minutes to start an IV. Exactly. And you know, that takes time. You know, if they're sitting there not breathing, you know, what we need to do is get the Narcan into them ASAP. You know, because the body can't stand to not breathe very long. So the quickest route is intranasally, the safest route and the quickest route. They're not getting as much of the drug as they would, you know, intravenously, but it's the quickest way, safest way, and it's pretty quick. You know, for the times of giving intravenously, we're talking probably within 45 seconds, maybe a minute, that it'll work, and it's weird. They go from being on death's doorstep to waking up and asking for a Pepsi. I mean, that's how quick it works.
How long does it stay before it starts?
That will depend. That will depend on the drug they take. The drug they take, how much of that drug they take. You know, and the hospitals will monitor these people. And, you know, when we transport them to the hospital, they'll monitor for so long. And, you know, sometimes the Narcan will wear off, and the drug that they took will still be in their system. And you'll see them kind of start to go back towards that overdose state. You know, they just need to be redosed with Narcan. So, because we need to give this to them as quickly as possible, and this is, like I said, the safest route, this is how we're giving it 99% of the time, is intranasally. And also this is, you know, the method that's being marketed to the public. It comes in a kit like this. You have what's called the system right here is called a Bristajet, and you take this vial and it screws into this syringe right here, and this is called a nasal atomizer. And what happens is when you push that vial into the syringe, it atomizes that drug into a mist, and that mist goes into your nasal passages, and it gets absorbed through your nasal mucosa. And then into your vasculature, and then circulated through your body to the opioid receptors, and then reverse the overdose. Intranasally even works pretty quickly, 1 to 3 minutes on most instances is what it takes to wake someone up from an overdose with intranasal
And you
narcotic.
have to make sure the respiration, you don't redo that, or it's.
No, well, we'll be supporting their respirations because, yeah, they need oxygen, but that won't really affect
But you can't just do it on a dead stop, like hit them without them breathing,
Yeah, well, I mean, we'll administer it and then keep breathing for them. You know, the respiration and the ventilations that we're providing them don't really affect that. It takes 2 seconds to, we'll start breathing for them, we'll stop for a second, administer it in each nasal passage, and then, continue ventilating for them until they, and you'll see them start to breathe again, and then they start moving, and then, their eyes open, and then they kind of sit up, and it's, complete turnaround. So what are the solutions? Like, people ask, like, okay, how do we fight this? Like, how does, where is the end in sight? Better access to treatment centers and programs. Like I said, New Hampshire didn't have very good treatment centers in the past. Thankfully, we are seeing that turnaround. I think the other day, I saw Hope for New Hampshire Recovery Centers opening in Claremont and Derry, and I know one opened in Concord a month or 2 ago. And this is so refreshing to see, because I mean, back in 2014, the governor really authorized the widespread use of Narcan. And before, it was just really healthcare providers that could use Narcan. And what that law that she signed into play was letting pretty much giving access to everyone, letting doctors write it for prescriptions. And I believe that is very, very important, and it saved many, many lives. However, it does not fix the epidemic problem. And although it does save lives, it almost in some sorts, prolongs the problem, and just, I don't want to say AIDS, but, if these people are brought back, and unfortunately, a lot of time that near-death experience and being brought back to life with a Narcan is not enough for these people to realize that they have an issue. It's not uncommon for us to, revive an individual multiple times. I mean, it's not common. Unfortunately, at Hooksett, our numbers aren't that bad, but I, myself have gone to, individuals in Hooksett and said, geez, I just did this, a couple of months ago with this guy, and, they just, so seeing these treatment programs and these centers and is refreshing. Me as an individual and as a healthcare provider who's really on the front lines of this, it gives me a lot of hope.
If I could get in here, from the law enforcement side of it, we don't have a slide on it because it just became, it's pretty recent. It's been said a lot that we can't arrest our way out of this problem. We're not going to arrest the people that are overdosing. But just recently, New Hampshire passed a law, it's actually called death resulting. So what they have recognized is, well, we can't arrest our way out of these overdoses. We're going to start going after the people who are providing these drugs to these people. So the Attorney General's office actually has kind of a task force now where they've assigned 4 different attorneys on this to deal with these types of cases. So in the past, just a few months ago, when we would respond to an overdose death in Hooksett, we would treat it more like we call it an untimely death or early overdose. We're now, just starting with the one we most recently have, we've changed our entire approach to it, where we are approaching it as a crime scene. And we don't know if we're going to, at that point, someone's going to be charged with it. Now, unfortunately, the person is deceased, so we went into a different mode with the most recent one we had, where now we are treating our evidence collection different. We're treating pretty much every way we handle these differently. It's more time consuming, it's longer, but we don't know what the outcome is going to be with the one we just had. What we do is we contact the AG's office and we look into all the scenario involving the certain overdose that we just had. It's very difficult to prove because pretty much, they told us pretty much you have 6 weeks. 6 weeks to try to get your case together because it takes 6 weeks for after the autopsy for the toxicology results to come back to show whether it was heroin with fentanyl. So in that 6 weeks, so we start right at the scene where we're going back gathering cell phones, search warrants, searching rooms, searching cell phones, interviewing witnesses, doing a timeline back. The one we're most recently working on is following this person back where they were for days previous, follow them from where they're going, where did they possibly get this drug, who were they with, did somebody administer it to them, did they administer it to themselves, did they choose to take it. So that's caused us quite a bit more work in a positive way, where now the result that we're seeing from that is these drug dealers are getting a little nervous about it. Some of them are. They're making a lot of money, but some of the users, we just recently talked to one guy that said, you know, did you do heroin? He's like, no, I don't want to die. I want to get high. I don't want to die. And then, you know, then he also said, you know, I smoke crack. Crack isn't killing us. Heroin's killing us. But he also knows these drug dealers and users know the laws better than us sometimes. And, you know, what he said was, well, we're interviewing him, trying to make a you know, connection to whether he had any part out of this death or whatnot, because he knew the exact thing to say. If I didn't administer it, I didn't give it to her, I don't know where she got it, I'm not going to jail for that. Because it's actually, if they can prove it, and there has been a couple recently in the state, you'll see on the news, it's a second-degree murder charge. So it's equivalent to that. It's equivalent to second-degree murder. So, and it's a pretty broad law, which most of our laws are in New Hampshire. I've read it over and over, and it says, you know, if you're responsible, we have to prove you're responsible for providing the drug, administering the drug, pretty much any part of providing that drug or having to do with that overdose death. It can't just be the overdose where they survive. It's pretty specific, it says death resulting. So this epidemic hit us fast where law enforcement is playing catch up, and we're you know, that's what we're trying to do, but at least we're trying to do something. We're not treating them just like, oh, I mean, because this is somebody's family member and somebody's, you know, spouse, child, and a lot of people say, you know, why not, you know, they're drug addicts, let them die, they chose to take the drugs. But when you have to go to somebody's family member and do a notification and say, you know, see their mother, father, they have a family behind them. These people don't want to die, they don't want to be addicts. It's just what's happening. So there is people, it's deeper than just that addict.
Are the laws sufficient, or is the evidence too overwhelming that you need to collect to have someone that the fire department may revive and they finally say, I need treatment, I'm done, and where did you get the drug? And it's just his saying, well, I got it from some guy named Lou on Valley Street. Is that enough
to go arrest
start?
Lou?
Yeah.
It's enough to start. It's not enough to go arrest Lou. What we would do is we would work back, and you know, we have a lot of contacts with different other agencies, drug task force and so forth, and know the ins and outs of these people. So one example they gave us, there's a case recently in Atkinson where there was a girl that she actually overdosed, she died. Word travels fast in the drug community of who's dead and who's not, because sometimes they actually want that drug because it's such a good high. They think they can control it and it won't kill them. But they actually took her phone, acted as her, the police did when they arrived. And they could see right on her phone, and everybody has cell phones nowadays, you know, where she just made the deal. So they actually called the dealer, acted as her, as a text, and said, can you meet me, I want some more. And he fell for it, he didn't know she had died yet. They went and met him, arrested him there. While they were arresting him, they want to go to the bigger dealers. So then, okay, you're going to work with us. So they actually did it a few times, going up the chain to find the bigger dealers. So that's just where they're getting creative. But that's a time-sensitive issue. You're going to be on it pretty quick and respond to it fast and be able to work like that. But then again, you know, sometimes we can't get into their phones, or we don't find anything in their phones. It gets frustrating because you try, but it's a lot to bring it all together. You got to have proof. before you're gonna charge somebody with
I
it.
don't know if you can answer, but you guys work closely with the Northern Task Force, doing the drug task force up here?
Yes. I won't go into specifics on that, for
Yeah,
obvious
no,
reasons,
no,
but,
Do
yeah.
you guys find that you can get, since, I mean, is it that much of a problem in books within books that you need more head count in books of PD to deal with that? Like more investigators and things like that, or just where you're at right now with what
You mean with us getting more personnel?
Yeah.
Well, the town's been very supportive of us. We just had some new positions approved in the budget. So I think overall, we are in the process of getting more positions, which in turn creates more detectives and more investigations and so forth, yes.
Yeah, you mentioned it takes 6 weeks to get the autopsy report back. Why so long?
I think it's a different, I don't know exactly, I know they're backed up, as
Yeah, I
awful
think
as that
that's
sounds. The
one of
one
the-
that we had recently, our medical examiner came out, it was 7:30 in the morning, was the fourth one he couldn't do that day. So there's just that many, and just the process, I guess, it takes to get the results back.
When I started talking about the solutions, I think it was you that was talking about, the drug police and, what Janet was saying about, the police not going after the individual, the user, it's not really going to solve this issue about them going up the chain and targeting those people who are the drug dealers and distributors and manufacturers, that sort of thing. I mean, that I think has more of an effect than, targeting the individual. The individual is the one that, really needs the treatment programs and the help. But I mean, this as far as like what the state has, you know more about this, about what they have for like drug task force and attorney generals. I mean, there are drug-specific policing out there that with the state police and attorney general's task force, and then on the federal level with the DEA and the Homeland Security.
There's lots of different agencies working together to combat this, whether it's at the federal level, state level, county level, that they're all working towards the same common goal.
And education prevention. And these three things I think are what gets us out of this. And the better access and the more availability of treatment centers in the program, and the change in the policing, and the more drug-focused policing that goes on out there, and then the education and prevention. I mean, what's happening right here. Let me ask a question. How many? Raise your hand if you know someone, whether it be a family, friend, coworker, neighbor, know somebody who has had an opioid problem. So about half. That's a lot. That half the people in here know somebody with a problem, and I mean that kind of shows you like how widespread and how bad this problem has become. So I mean, as individuals, what can we do for those people we know with problems? Getting the knowledge, and the education. Just like what we're talking about right here. Be a good listener. Don't overreact. The last thing these people want to hear is, you shouldn't do drugs. You're hurting yourself. You're making bad decisions. Yeah, the last thing they want to be is lectured. A lot of times these are good people. These are normal people like you and me that just got hooked on a bad problem. You got to look at addiction as a disease, and I think once you can do that, then you're able to properly, figure out how to fix it, and treat it properly, and so forth. Set clear expectations and give honest answers. Be honest with these people. Yeah, absolutely.
Be a good listener, don't react, I get all that. Then there's that balance
I can imagine it's tough.
between, being a good listener and enabling and that whole scenario,
Right.
so.
I mean, I guess with that, what you want to do is, that individual has the problem, you want them to be comfortable coming to you. And you want them to know that you're someone that they can confide in. And, you know, if you make them uncomfortable, if you just sit there and lecture them, they're gonna go somewhere else. And so it's, you know, going about the right way, I guess. And, you know, letting them know that you're somebody that they can go for help, and then, you know, by listening to their problems and you know, help establishing that relationship, you can then, you know, help guide them to programs and, you know, peer recovery coaches and other types of programs.
Not be judgmental
Yeah.
too. I mean, don't if you're up, if you're in your actions and your tone, be judgmental. You're not going to have a relationship with trust. You have to be careful that we all have judgments of what you think people should be. And I've worked in this for many years, so that you know, try not to show that you're judgmental because you're going to lose them.
Yeah, and you know, as big as this problem is become, I used to work part-time for the ambulance in Manchester. Saw a lot of these overdoses, and obviously in Hooksett too. As much as it happens, and sometimes the lack of lack of compassion, lack of respect for these people have for themselves, and we've revived some people who have overdosed, and they've told me to get the F out of their apartment, and literally just saved their life, and you know they're you know yelling at us, telling us to get out and stuff, and it's tough to maintain that non-judgmental and level of respect for these people, and ultimately, I guess, you know, on the farm, we just need to remember that, you know, it's our job to help these people and treat them, not to judge them.
Well, I think too, if you have your own autopsy, if you have evaluation of what happened, as you really become stronger, you go over it with your own human, and it's easy if you see this, and it happens more often than not.
Yeah.
You know, you can lose yourself in it too, so the providers have to take care of themselves.
Yeah. Knowing the warning signs, you know, aside from the physical warning signs, there's also the behavioral side that, you know, can be caused from this, you know, addiction. Changing their attitude, personality, isolation, being overly sensitive, you know, a temper that, you know, can go off, seemingly nothing. Change and loss in interests and habits, school, friends, difficulty paying attention, forgetfulness, nervousness, irritability, dishonesty, needing for money, just odd behavior, change in behavior. Physical signs, slow, staggering walk, inability to change, inability to sleep and change in sleep habits, eating, appetite, eye, skin changes, tremors, shaking, you know, the withdrawal symptoms we talked about. You know, we've gone to ambulance calls with people who called the ambulance because their withdrawal had gotten that bad, and you know, you feel for them because you can tell they're absolutely nausea, vomiting, sweating, you know, track marks on the arm. Knowing the gateway drugs, you know, I mean, the thing to bring up is nobody woke up one day and said, I'm going to try heroin tonight. That's, you know, doesn't happen that way. Gateway drugs, cigarettes, alcohol, marijuana, prescription medication, obviously that last one is, you know, has played a big part into, you know, this epidemic. Look at some of these numbers here. By 12th grade, 50% of kids have tried marijuana, 60% tried cigarettes, and 75 have tried alcohol. That's scary. I got a 2-year-old, and that frightens me. So with prevention and education and intervention, where and how does this happen? Schools and colleges need to get involved. You know, providing that, you know, access to the first step, if you want to call it that, and providing, you know, peer coaches and individuals, they can confide and get information from, get help from, get, direction, resources. That needs to happen from healthcare providers to their patients. We need to be able to provide that help to our patients, if they use their businesses to their employees, through, employee assistance programs. Somebody has an addiction, a problem, it's, cutting them loose and cutting ties and firing them isn't gonna help these people, realizing that they have a disease and have a problem, helping them get through that, is the right way to go about that. Friends to friends, parents to children, obviously educating them and, educating them from an early on so that, when they come about those scenarios and times when they're faced with, drug use or asked, hey, you want to try this, you want to try that, giving them the knowledge and the education and the power to know what it is they're faced with and what choices to make is very important. The last time me and Sergeant Bouchard did this presentation was at College Middle School, was to try and get across, get some of this information across to the parents and to the teachers. Prescription drug monitoring programs, this is something that's kind of taken off and been fairly successful in the healthcare side. They've got this statewide database now where no matter where you are, whether it's the ER or your primary care physician or say an urgent care center or wherever, they can go on this database and see what you've been prescribed for medication. So, that term doctor shopping, is